want to bring up the word cloud and start to have a look at what disability looks like from our kind of gut feelings. Challenging. I love that. I'm not going to read them all out, but we're going to each introduce ourselves briefly, and then we'll get into talking about the main things that we think of when we think about disability with regards to our healthcare access. So I'm Gillian, as I said before. For blind and visually impaired people, I am a tall, thin white woman. I'm wearing a colourful skirt and pink shoes, which are my personal favourites. And yeah, I am a physiotherapist who works in rehabilitation research. My pronouns are she and her. I'm queer, I'm a mum, and I think they're all the kind of important things about my identity, as well as being disabled. Jean-Frédéric.
Thank you, Gillian. My name is Jean-Frédéric Lévesque. I would like to say I look like David Bowie, but unfortunately, I know my kids would probably say I'm a middle-aged man, and probably a bit nerdy. So I wear thick-rimmed glasses, and I'm not really tall. Professionally, I'm the Chief Executive of the Agency for Clinical Innovation. I'm a medical doctor by training, and my clinical practice was mostly with refugee claimants in Canada, where I'm from. And I've been in Australia now for 8 years, previously leading the Bureau of Health Information. So I do have some professional experience that relates to the topic of the session today.
Thank you. And Jono.
Oh, hi, guys. I'm Jono. I'm a thin Asian guy. I'm wearing a black coat shirt and some creamy pants. My wheelchair is nice and black, but my front wheels, if you haven't noticed, actually sparkle. So it's like wearing those little kids wearing those shoes when they walk and they sparkle. And sometimes in the shopping centers, we sort of eyeball each other and have that look. So quite cool. I'm a PGY1 intern at Royal Prince Alfred Hospital. On my medical term at the moment, I'm in renal transplant, so like a super generalistic, easy term to begin with. But med school wasn't always that easy. I broke my neck about 9 years ago from a trampoline accident. At that time, I was trying to qualify for the national team, and I broke C5 and 6. So, as you know, with the spinal cord injury, there's lots of things that go on, and sort of lack of movement is just one thing. So, there's spasticity, there's bowel and bladder dysfunction, there's autonomic dysfunction, so I'm no different. But I'm very, very glad to be here today with you, because it means I don't have to round the boss this morning.
Awesome. And Naz is also part of this panel discussion. So when you're thinking of questions to put to us on Twitter, include Roger, then yeah, you can direct them to any one of us or just in general. So my main thing, if I was going to have one word that I think of when I think of disability, I think I just press pause rather than progress slide. Good on me. Can someone progress the slide for me? Because I have not worked out how to do it myself.
Try this
one. Yeah, try that one. Anyway, hang on. Anyway, that wasn't going to be the first slide, but it can be now. So these are all the different parts of me. So yes, I am sick. I've got a peripheral neuropathy, which is an autoimmune cause. It's chronic inflammatory demyelinating polyneuropathy. And also I have Ehlers-Danlos syndrome. So the disabilities that I have are mostly invisible, but there's motor sensory problems, there's autonomic dysfunction, bowel and bladder problems, and I spend a lot of time having infusions, and I'll get into kind of how my experience in the healthcare system throws up access barriers a lot. I also, I'm a mum. So in managing all of these things, my word is busy. Like, I'm really, really busy, and not to, go, we like to talk about how busy we are, because I think that's kind of some way of valuing ourselves as productive. But my busyness related to healthcare appointments is a massive barrier for me actually having enough time left to work. So what I decided to do with all my free time a little while ago was do a diary review of 9 years of my life, and I had a look at, split up the waking hours. So 8 hours in a 24-hour period is gone for sleep. This is a representation of, and on the screen it's like a donut chart. It's a representation of all of the waking time that's left. So my health appointments take 15% of my waking time, averaged out across a year on a diary review. So that's a real lot of time. Then for the chronic condition self-management stuff that I'm supposed to do to manage my health, anything extra than what anyone would reasonably expect, if they didn't have a chronic illness or a disability, that takes an extra 10% of my time. 30% of my time's in work if I'm working full-time, and that leaves 45% of my waking hours to do other stuff. So that's 3.7 hours a day, averaged out across a year. Like, yes, some of that time might be I'm in surgery, I'm in hospital for 3 or 4 days at a time, but across the year, 3.7 hours per day is needed for me to manage my healthcare, attend health appointments, including travel. And that's my experience, but that's actually backed up in other research looking at chronic condition management. You're nodding furiously, Jono, going like, yeah, it takes all of this time to do health management stuff. So just in the last year, in 2020, I saved 46 hours in travel because some of my health appointments were offered via telehealth. So that's a lot of time where I can earn money and not lose my job from not needing to take all. That was just the travel hours. So telehealth is not the solution to everything, but every time you're thinking about, should I offer a person a choice of face-to-face or telehealth, whether or not they look like they're from a rural place or they look like they're a person who physically will have more difficulty accessing the service, like just offer it to someone if you can. And if you're designing health services, I think I want you to take home the thought or kind of reflect on how convenience can actually be an access and inclusion issue. So if I cannot work within the health system because I'm always at health appointments, then I can't earn money, and we know that not having money leads to bad health outcomes. That's my kind of introduction to there. Have we got any comments or questions about healthcare system logistics or convenience?
So we haven't got any questions on convenience as such as yet.
Then perhaps I might, because you were nodding so furiously, do you want to add anything talking about just logistics of healthcare and like the value of our time?
I think I'd fully reflect on some of those things you said in the past. Going to health appointments, but actually seeing the doctor is only a minute part of the whole experience. I think as health professionals, we only see people when they're there in front of us. And a lot of times you don't think about the things behind that. So, for example, the actually taking time off work to get to the appointment. Then you might need to drive. Then you might have to sit in the waiting room, sort of thing. And then there's also going back. So you're leaving, you're going to the car park. You're trying to arrange your day around this whole appointment. So I totally agree. It's definitely a lot of work, and it's a lot of commitment to looking after yourself.
Yeah, and Naz, have you had the option given to you about how to actually, whether or not you should have a telehealth or a face-to-face appointment?
And recently my GP, when I called to make an appointment, said, oh, love, you've been here 2 times this week. Why don't you just have a phone interview and a phone appointment? And I was like, well, I didn't know I could have a phone appointment. And so you just book it in, and it was amazing to be able to do that. And I thought, why haven't I been doing this for 30 years when, obviously there are some things that you absolutely need to go and see someone face to face, but a phone or telehealth appointment, that's the journo in me, appointment is just so convenient, and it means that I don't have to have that sort of stress of relying on other people to get me there. Either paying a lot of money for taxis or relying on someone to have the time to take me, or getting public transport.
So, we're hoping that choice, and I think you're going to touch on this a bit later, John Frederick, choice is really important, but not just kind of as a nice touchy-feely thing so the person feels like they were listened to. Like, it leads to actual health outcomes and your ability to be employed and things like that. I went over and above with going for my access needs. I was in a relationship with the telehealth manager for my local health district for 4 years. And even then, not to get telehealth appointments, but even then, knowing all the insider stuff that I did, I still had to have these arguments with administrators and reception desks about when they'd say, oh no, telehealth isn't available to you because you only live half an hour from the hospital. And I'm like, I know it's available to me. I know how the billing works. I know this. And still, it's always... And this kind of relates back to the trauma. You're always put in a situation where you're having to justify what your needs are when you're actually only asking for something possibly that exists and it's available and it's an option that you knew you had. And then I've been kind of berated loudly in waiting rooms by people saying, but you don't live rurally, that's not for you. And anyway.
I think it's not only based on your location of where you live, it's also... in the past, I know that people who have invisible disabilities, for example, have asked for some accommodations to be made, and they almost have to fight to prove that they require that adjustment, and often they're made to feel bad about it, and I think that's something that can often get in the way as well.
Yeah, absolutely.
Yeah. I think basically what we're trying to tell you is that having a disability requires a lot of time. And when you're thinking of planning to do, whether it's appointments, whether it's procedures, that there's lots of things in the background that you can't see. And I think that's why when I do talk more about my area, it's about understanding the lived experience. And while not everyone needs to have a lived experience to be an effective clinician, listening to more stories and being involved in that aspect can actually deliver better patient outcomes.
It's probably, and because you're going to add to this, so I realise that we've ignored you so far. But Jono, do you want to just bring up the word that you've thought of as kind of a really important word for you when thinking about disability?
Yeah, so I mean...
So if we could just put Jono's slide up.
So when I did this exercise, the word I came up with was actually workforce. And this isn't about having quotas or anything, but actually thinking about people with lived experience or disabilities in the healthcare workforce. We know diversity is such an important part. We know that, for example, having gender diversity improves patient outcomes. You reduce error, you reduce length of stay. And that's been shown that places that have better gender diversity actually have better outcomes. So it's a no-brainer to say that if you have a more diverse workforce, it can be better for everyone. So I want to share a little story about about when I first started RPA, that sort of highlight some of the inequities that sort of I faced. So, when you first start in a new term, you have to, arrange your med term, your surge term, ED relief sort of thing. And so I went to my JMO manager and, we had a chat, what was the most easiest thing and what was the most, how were we going to arrange the year to be successful? And it was a really good conversation, and I, got home and, really looking forward to this year. And about a week later, I got a phone call from her and saying, oh, look, there's some problem. And I was like, my first thought was, oh, what, so you couldn't roster me for like 5 orthopedic terms, But no, all seriousness. What happened was, in arranging my surge term, one of the head surgeons there heard about me. So there's this new intern starting at PA, and he's in a wheelchair. And basically, what he said was, no. He said, no, he's not allowed in theatres to scrub or assist. Just black and white. And initially, I was a little bit taken back. I was like, oh, yeah, okay, that's not quite right. But look, wasn't a surprise to me. Maybe he just didn't understand who I was, sort of what I did, sort of thing. So, some of the strategies which I came up with, or maybe I'll talk to some of the bosses at North Shore where I was as a student, like how do we overcome some of these problems? And we had a discussion, and maybe he just didn't know how I scrubbed or how I assisted. I mean, at North Shore, I helped with cesareans, I assisted, I was holding retractors, the worst thing ever, but help close, and we came up with a few strategies, how to approach it. So when I spoke to the bosses there, their first reaction was outrage. They were outraged that this was even an issue. And the reason it was an issue, it wasn't like they were outraged, is because, I went through the same medical training as all my peers, and it was only because I'm in a wheelchair that I had to prove myself. And so I was a little bit surprised too, because I've never really thought too much about myself. But it goes to show that, maybe because I'm so used to casual discrimination, and a lot of people with a disability are so used to being discriminated against that it didn't even register with me. So it goes to show that people with disabilities face lots of barriers, but the biggest barrier is actually attitudes and beliefs. And so one of my points I wanted to take out of the story was I wanted to challenge the audience that, if ever you have a colleague that comes across with a disability, don't be afraid to ask. Don't be afraid to know a little bit more, because challenging the normal perception of disability is what we need. We need to normalize it and not make assumptions or not assume, but actually understand what people's abilities are and what limitation they may require. And touching on what Naz was saying, I'm actually quite fortunate because my disability, I stand out. I'm in a wheelchair. People feel sorry for me. But a lot of people with disabilities are invisible. So whether it's a mental health, vision, hearing, whether it's behavioral, they fight really hard for the support they need. So if we want to look after our patients, we've got to first look after ourselves.
Yeah. If I could add two things to what Jonathan has said. Firstly, people with disability are so used to discrimination. It's terrible, it's sad, but it's fact. We are so used to it. And I think there's nothing casual about it, quite frankly. Discrimination is discrimination. And so that's the first point I'd like to make. But the second is that research overwhelmingly shows that people with disability are just as hardworking, just as productive, take less sick days, and because of the nature of the barriers that we face because of society, because of the environments around us, we are incredibly resourceful and adaptable. And so we are constantly thinking of ways to get around whatever it is, whatever attitude you have or poor access to a building. We are constantly innovating and thinking before anyone else is about how we will navigate something. It shouldn't be on us to do that, but that's the reality, unfortunately, that we're faced with.